Okay, so this is a mouthful. Personalized quantitative evidence-based treatment for bipolar disorder. So unlike Rajiv, I'm not on the DSM-5 panel, and this is why. Okay? I think it's my job to be able to say something good and bad about every treatment, to be able to characterize it. And so I think, really, it probably makes sense to have some people who are on site when these things get developed be academics. And so our group has participated in pivotal trials as well as investigator-initiated studies. On the other hand, having people at arm's length from it can give you a complementary point of view. So I hope the one thing you might think is, okay, well, he's biased towards medicines because of this. And probably the best kept secret in bipolar disorder is that adjunctive psychotherapies have effect sizes comparable to medicines. Adjunctive psychotherapy for acute depression and maintenance, not for mania. Forget that. Okay, and that being said, I think that's some evidence that there's some balance between being overly enamored with these medications versus disdainful of them. I've been trying to think of how to make my disclosure be advertising. And so there's got to be a way to do it. Okay, so I could be trying to sell you a book. Okay, you need to look out for that. All right. And this is a slide we recently put together, and I won't dwell on it, but it's the other side of this conversation. Okay, the strengths and limitations of having people who have non-null disclosure statements. Okay, so you want a variety of people. There are studies in creativity, and we run a creativity class at Stanford. And in looking at group creativity, one of the key elements is getting people with different points of view together and different experiences together. And that's one thing that is stimulating about this particular panel that we have. So looking at bipolar disorder, and so now this is, I think this is a little bit different from what I presented 4 years ago, okay? And so this is based on attempts to really quantify benefits and harms. And so when we're making these decisions, and you're looking at the different steps and things like that, I mean, in some circumstances, you're in the situation of first do no harm. These may be situations that are a little less acute, a little less dangerous, a little less severe. Other times you're in the situation of damn the torpedoes, get the job done. Okay, those are going to be the more severe, more acute situations. So for bipolar disorder, the way the FDA approves things, they do it on phase of illness, so acute mania, acute depression, and maintenance. And effective treatment is going to be some kind of a balancing act of benefits and harms. And there's lots of ways to do this, okay? This particular presentation looks at number needed to treat and number needed to harm in developing some kind of a benefit-risk ratio. And so when we're making our decisions, we need to look at the treatment phase, and that's why in the guideline you see more, acute mania, bipolar depression, maintenance. You need to look at the benefit-risk ratio, and we got into this with Rajiv's presentation some, accounting for individual characteristics and preferences. It's absolutely key. And boy, that's hard to write into guidelines. Okay? And in fact, that is so important, and it's somehow, it kind of just evaporates in the guidelines. So this is what we have to work with. Okay, and so 1 out of approximately 10 first-generation agents is approved, first-generation antipsychotics approved for bipolar. 6 of the second-generation agents approved for bipolar. So there's one difference between the first-generation and second-generation agents. A first-generation agent that probably ought to be up there but isn't, in spite of the data existing, is haloperidol. Okay, for acute mania. This column is not our main problem in bipolar. Okay, we're actually doing pretty good there. And the most pervasive phase of the illness is, active phase, is depression. Okay, on average, half the time the patients are okay and they're complaining of side effects. The other half of the time they've got some kind of mood thing going on, and most of the time it's depression. Okay, so this is kind of ironic that the most pervasive phase has the fewest indications. Okay, we used to not have much in the way of options for longer term treatment, and what has happened is that at least 5 of these second generation antipsychotics have migrated from acute mania indications over to maintenance indications, and what most of them do is prevent mania. Okay, so the old thinking 2 decades ago was the maintenance treatment is lithium. Use first-generation antipsychotics for mania and antidepressants for depression. And antidepressants in the longer term are a problem because they prevent depression by causing mania, and antipsychotics in the longer term are a problem because they cause TD and they fight mania by causing depression. And that's kind of gone away now, because it looks like at least some of these second-generation antipsychotics, in fact, not only are not dysphorogenic, they may even be a little bit antidepressant. Okay, and so there's complexity. There's a richness to these antipsychotics, and depending where you are, different features are going to have different attractiveness. There are things that are missing here. Okay, negative studies with aripiprazole and ziprasidone, 2 double-blind placebo-controlled studies each. In acute bipolar depression, they didn't make it. Okay, despite all the efforts of GlaxoSmithKline, lamotrigine didn't make it in this column. Okay, so it hasn't been for lack of trying that middle column is so short. Okay, it's a tougher problem.
Has lithium been subjected to the trials?
Lithium has, not in the fashion that would be the most fair. Okay, I saw Lakshmi Adam at the last one presented the Embolden study where a level of 0.6 was the mean lithium level. Now, if you want to be nice about it and dose it nice, that's a fair trial. If you believe some data that say you got to try to get it to 0.8, then that's not such a fair trial. Okay, so I don't think lithium has been fairly tried. It's probably the case that divalproex hasn't really been fairly tried. Lamotrigine has been fairly tried, and it fell short of the threshold necessary to get FDA approval. With 100 patients in each group, you don't have a big enough effect size to separate from placebo. You put 5 trials together and 500 in each group, then it separates. Okay? So I'm going to be talking a little bit about that notion of effect size and just how big. So one of the key questions is if you've got a dearth of agents here and these seem to have too many side effects and this is the main problem, where are you going to go looking? Well, mood stabilizer is a good place to look. And unfortunately, we don't have enough data on lithium. We probably have enough data on lamotrigine. It's just not potent enough to get an acute indication. Okay? And some of these other ones, well, we've got the data that aripiprazole doesn't make it for acute bipolar depression and ziprasidone. So we get, and you can wave your arms around and say, okay, well, it was a dosing thing or this or that or the other. These companies are trying hard to get something approved when they're spending this kind of money. And if they do 2 trials and it doesn't make it, I don't care how much is wrong with the trial, there's probably something wrong with the drug. Okay? So the atypical antipsychotics are not a unitary group, okay? And I don't know what to make of the fact that these are both penes. Who knows? You need a longer. You need a longer list than 2 to create some kind of pattern. So originally, when I got started in this area, I was very interested in carbamazepine. I did my fellowship with Bob Post, and then divalproex, and then lamotrigine, and I didn't have a whole lot of passion for first-generation antipsychotics. I saw them as unimodal agents. The second-generation antipsychotics, they're harder to ignore. They're harder to ignore. The reason I was kind of looking for something to separate them is because, at least in the minds of people who treat bipolar disorder, there's a pretty negative view of first-generation agents. Okay.
In that affective disorder, risk factor for TD relative to schizophrenia, are they more likely
Mm-hmm.
more severe?
There's that. That being said, I got a patient or two, the very best thing they ever got, compared to anything on this list, was 0.5 milligrams per day of haloperidol. The best treatment ever for that person. That kind of stuff just doesn't happen often enough. It's not a population-wide effect for the first-generation agents to stay on the radar in bipolar disorder. Okay, so I'm going to go over the different agents in terms of benefits and harms. And there's lots of ways you can say something works. There's lots of ways you can say how much it works. Okay, and you can go with effect sizes, which is the difference in terms of units of variation. Okay, it's a little bit nerdy. This is a little less nerdy, but it's still kind of nerdy. And for the number needed to treat, what you do is you take the drug, say response rate if you're doing response, minus the placebo response rate, take the advantage over placebo, okay, and then divide it into 100. Now, if you didn't want to do division, you could just say, well, what percentage better than placebo is it? So you could do it that way too. It's an effort to quantify the size of the benefit. So we've got benefits and harms, and clearly, if something gets FDA approved, it's got to have some benefit, you would hope, okay? But it may not be very big. And if something doesn't get FDA approved, it doesn't necessarily have no benefit, but it may have fallen short of the threshold for benefit, or it may have had a harm that was a deal breaker. So even though quetiapine has the data for monotherapy in unipolar depression and generalized anxiety disorder, the FDA is taking a pass on that, okay, because to give that an indication suggests that, in fact, it could be a first-line agent. And they want to steer people towards agents that are better tolerated. So even in the indication process itself has a component of balancing benefits and harms. So the way these work is a single-digit NNT means you beat placebo by at least 10%. That doesn't sound like it's putting the bar way too high, okay? The way it turns out in bipolar, and this is not the way the FDA makes its decisions. The FDA makes its decisions based on a reasonably powered trial, say 100 in each group, getting a separation from placebo. Okay, for whatever reason, the way the universe is organized, that translates into the FDA-approved agents for bipolar disorder having single-digit NNTs. So they're beating placebo by at least 10%. Okay? So that's a little dose of reality for us. Okay? So the bar is not like super high. And so there's this tendency in clinicians to overestimate benefits and in patients to overestimate harms. And I think this can lead us to understand how that works. And so, you know, I'm sitting around my office on Wednesday and look around in the waiting area, and among these people who were depressed last time, you know, half of them are okay, 2 of them are okay, and the other 2 are still depressed. I think, well, I'm batting 500 at least. You know, it's as good as a coin toss. What is not so evident is that as a direct result of the intervention that was recommended last time, either psychotherapy or pharmacotherapy or whatever you choose, only one of those 2 people who are looking better is in that state. Okay? Now, some clinicians say, well, I don't care about that. I never use placebo anyhow, so I don't, this is all that matters to me. And there is some validity to that argument. Okay? So what I'll present today is all on response rather than remission, the reason being that remission has variable definitions in bipolar disorder. Okay, so some people are very concerned that you can get remitted from depression by getting manic, things like that. So a response in bipolar is a 50% improvement, okay? And in general, if we look at everything we do with approved agents, about half the patients get 50% better. That's, you look at epilepsy, look at seizure counts and things like that, it's similar, okay? So it's not great, it's better than nothing, but about half the patients get 50% better. And of the improvement we see, about half of it is coming from interventions non-specific to what you just most recently did. So this could be depression's got to end sometime. It could be a positive life event. It could be some nutraceutical the person's taking. It could be our absolutely engaging personalities when we're doing pharmacotherapy visits. It could be raising expectation of cure. I mean, there's a lot of things besides a sugar pill effect there.